we will also discuss about how these patients with brain tumor present, how these are investigated, and what is the treatment of brain tumors, and what are the recent advances in its management. This is a anatomy of the brain, and if you look at the brain, there are four lobes. One is the frontal lobe, one is parietal, one is occipital, and one is temporal, and these are on both sides. In addition to these lobes, there are other important structures. The important one is cerebellum, and there is brainstem. So the whole brain that is lying inside the bony cavity, which is called skull. And in the skull, there are three compartments, three foci. One is anterior cranial fossa, other is middle cranial fossa, and one is posterior cranial fossa. So in the posterior cranial fossa, cerebellum and brainstem are lying there. Again, this slide is showing about the anatomy. And if you look at this one, there are two hemispheres. One is the right one, other is the left one. And we can see the frontal lobe, which has three parts: superior, medial frontal gyrus, that is middle frontal gyrus, and that is inferior frontal gyrus. This one is the central sulcus. Anterior to the central sulcus is the motor strip, while posterior to it is the sensory area. This one is parietal lobe, and that is the occipital lobe. This one is the midline. So two hemispheres having the same distribution of lobes on both sides. A very important diagram showing different parts of the brain is we discussed in the previous slide. This is the frontal lobe, that is the parietal lobe, this is the occipital lobe, this one is the corpus callosum, that is the geno, this is the body, this is the roof of the third ventricle, that is the thalamus, and this is the floor, that is the optic chiasma, pituitary region. This is the brainstem, pons, medulla. This one is the middle brain. This is the fourth ventricle. That one is cerebellum. This is the aqueduct, which is connecting third ventricle with the fourth ventricle. Superior colliculus, inferior colliculus, and this important structure is the pineal gland. In the brain, if we look for its microscopic structure, we can have different types of cells which are making the brain. These are the nerve cells, neurons, which is having axon and cell body, and this axon is covered by the covering that is formed by the oligodendrocytes in the brain, while in the periphery that is formed by the Schwann cells. These are the ependymocytes, which is lining the ventricular cavity. This one is astrocyte, that is oligodendrocytes, and these are microglia. Why these structures is important? Because the parenchymal primary brain tumors are arising from these cells, and these tumors are named accordingly. So when a tumor is arising from the astrocyte, that will be astrocytoma. When it is arising from the ependymocyte, that will be ependymoma, and when it is arising from the oligodendrocyte, that will be oligodendroglioma. As there are many tumors of the brain, so their classification is must. Grossly, there are two types of brain tumors. One is primary, that is arising inside the brain parenchyma or inside the cranial cavity, while other is metastatic tumor. The primary focus somewhere else, and they are spread from the primary focus towards the brain. So as I mentioned, tumors might be arising from the glial cells in the form of gliomas. So these are further divided into the lowest grades, low grade, high grade, and highest grade, or grade 1, grade 2, grade 3, and grade 4. Why the grading is important? Because we can decide for treatment, and we can also tell and know about the prognosis of that particular tumor. So in the low grade, we have lowest grade, we have polycystic astrocytoma, subependymoma, ganglioglioma, and so this list of tumor is low grade. While here these are the lowest grade, and these are the low grades. So low grade can have the tumors which are in the low grade malignancy. These are fibrillary, astrocytomas, ependymomas, oligodendrogliomas. In high grade, we have anaplastic astrocytoma, anaplastic oligodendroglioma, and anaplastic maxglioma, while the highest grade is glioblastoma multiforme and gliosarcoma. So the prognosis is worst here, but that is good prognosis here. When a tumor is arising from the meninges, that will be meningioma, which can be benign, atypical, and malignant. This can also be arising as a primitive neuroectodermal tumor in the form of medulloblastoma, ependymoblastoma, and pinealocytoma. As pituitary gland is also a very important structure, so tumor can be there in the form of adenomas, carcinomas, or craniopharyngiomas. And the tumor can also be there in the pineal region in the form of pineal cyst, pinealocytoma, pinealoblastoma, and germinomas. Well, choroid plexus, as you know, that is secreting fluid in the form of CSF. But tumor can also be there in the form of choroid plexus papilloma or choroid plexus carcinoma. The other tumors may be neurocytoma, lymphomas, hemangioblastoma, hematomas. The tumor can also be arising from the nerve cells in the form of neuroma or their covering as schwannoma or neurofibroma. There might be cystic lesion like colloid cyst, arachnoid cyst, dermoid, and the other tumors which can arise from the skull bone and they are compressing and entering into the brain parenchyma. These might be chondroma, chordoma, sarcomas, and glioblastoma. As I said, the tumors can occur somewhere else, like a tumor can be in the lungs or it can be in the gut. So there it can spread from there and come to the brain in the form of metastatic brain tumor. Now, when a tumor is inside the brain, what will be its presentation? So presentation can be divided into two. One is general presentation and the other is local presentation according to the particular area of the brain which is involved by the particular tumor. So generally when a tumor is inside and that is creating edema that leads to raised intracranial pressure, so the patient will complain of headache, there can be visual deterioration, the patient can vomit, and when the cortex is involved, the patient can have seizures or fits. When a speech is involved, the patient can have dysphagia or there might be weakness when the motor step is involved. And according to the location, so if a pituitary tumor, the patient can have hormonal problems, and when its size is increasing, going upward, compressing the optic chiasm, and the patient can have visual problem in the form of optic decreased vision and in the form of field defect like bitemporal hemianopia. When lobes are involved, like frontal lobe, the patient can have personality changes, or parietal lobe, there might be changes in the sensation, or in the temporal lobe is involved, there might be changes in the memory. When brainstem is compressed, the patient can have lower cranial nerves involvement or other cranial nerves involvement, and there can be involvement of the long tracts like corticospinal tracts, which are affected, and the patient can have difficulty in walking. When cerebellum is involved, there will be loss of balance. And when a patient is having metastatic tumor, so we should look for the primary. Like if a patient is having primary tumor in the lungs, the patient will have difficulty in breathing, there will be chest pain or cough. So we should look for all these things. So from this patient, we should take proper history, and in the history we should mention and we should look for all these things. We should ask for all these things, and then this patient should be examined accordingly. So in examination, we should examine for the different lobes, for the frontal lobe, for the parietal and temporal lobes. Then we are examining the cranial nerves. We are doing fundoscopy. Then the cerebellar signs are checked, and the upper limb and lower limbs are checked for any sensory or motor deficit. The reflexes are checked, the power is checked. So in these patients, suppose if a patient is having a lesion in the motor strip, so in addition to these things, this patient can have papilledema, there might be visual field defect, and the patient will have weakness in the limbs on the opposite side. So the reflexes will be exaggerated, the power will be low, and the plantar might be upgoing. If a patient is having a lesion in the cerebellum, so in addition to the findings of the rest due to rest ICP, the patient will have cerebellar signs will be positive, like dysdiadochokinesia will be there. The patient can have nystagmus. There will be loss of balance. So these things should be looked for, and we should ask for all these things. This is a very important diagram showing different lobes and their functions and their signs. So in the front lobe, that is related with the personality, with the social skills, with the judgment, emotional regulation, movements, speech, etc. While temporal lobe is related to the memory, that is dealing combined senses with memory and recognition of the objects, while the parietal is there for depth perception, for the spatial orientation, for the sensory reception, and for the language as well, while in cerebellum that is for balance, learning, emotional regulation, and coordination, and basal ganglia for memory, emotion, and coordination. And when the brainstem is involved, the breathing can be affected, the heart rate can be deranged. There will be motor and sensory pathway involvement like corticospinal fibers or nuclei of the cranial nerves, and the patient can have presentation accordingly. So when we take history from a patient with brain tumor, and when we have examined this patient, then we should go for investigations. And we always divide investigation into three. One is the baseline, specific, and relevant. So baseline means that those tests which are done routinely, and these are done to know about the fitness of the patient, whether the patient is fit for any surgical intervention or not, or to go for any correction of these basic things if they are deranged. Like if a patient is anemic, that will be seen and the patient is having electrolyte balance, that will be also known if we go for the baseline investigation. Specifically, we go for investigation of the brain in the form of CT scan and MRI, and there are a lot of types of MRI. And along with the MRI, we also go for the angiography when needed. So CT angiogram or MRI angiogram is also done. And by relevant investigation, we mean that we will go for investigation other than these baseline and specific, which can help us in the diagnosis and prognosis management. Suppose if a patient is having a metastatic lesion, so we go for the relevant investigation to know about the primary focus. So CT chest is advised, thyroid functions are advised, ultrasound abdomen is advised, and they will tell us if there is a primary lesion in the lungs or thyroid or in the abdomen, which is might have spread to the brain in the form of metastatic lesion. In addition to its spread to the brain, there might be spread to the other structures and organs of the body like liver, like spine. So for that, if we are suspecting spinal mets or mets to the liver, so we go for the relevant investigations. So we should always divide our investigation into these three, and when we do it, then all important investigation will not be missed. Then when we have investigated the patient, so how that help us? If you look at this X-ray, this is X-ray skull lateral view, and this is the pituitary fossa. So when there is erosion of the pituitary fossa, it shows that there is a tumor in the pituitary from the pituitary gland or any structure lying there. There are multiple involvement, and this is a typical presentation of multiple myeloma. If you look at this picture, these are MR, and here, this is the frontal lobe, this is the temporal and occipital. So this is a tumor which is lying in the anterior cranial fossa, and this is compressing the frontal lobes. So the presentation of this patient will be two types. One due to rest ICP in the form of headache, and the other is it is compressing the optic nerves, the frontal lobe, and also the olfactory nerve. So the patient will have no sense of smell or decreased sense of smell. This will have frontal lobe signs in the form of personality changes, in the form of behavioral changes. And when the optic nerve are compressed, this will have also weakness of the, this will be involvement of the vision. And if you look at this lesion, so this tumor is arising from the meninges in the form of meningioma, and it is compressing the parietal frontal region. There is midline shift. These are the ventricle. The ventricle of this side is shift, and this fox is also shift there. So in such patient, we can have, in addition to the general feature like those of the raised ICP, there will be, when this region is involved, there might be weakness on the opposite side. So that this patient can have hemiplegia of the opposite side or hemiparesis. If you look at this MRI, there is involvement of the brainstem, so it's a tumor which is involving the brainstem. And in addition to the signs symptoms of raised ICP, there will be involvement of the cranial nerves as well as the long tracts. So this patient will have deficit of the cranial nerves, like facial weakness, or there will be, when the corticospinal fibers are involved, so there will be difficulty in walking. While here the cerebellum is involved, so in addition to the other signs symptoms, this patient will have cerebellar signs in the form of nystagmus, in the form of dysdiadochokinesia, in the form of loss of balance, in the form of tremors. The Hilshin test might be positive, and so we should look for all these things. And again, this tumor is outside the brain and might be arising from the meninges in the form of meningioma and compressing the brain, while here again in the posterior fossa involving the cerebellum and compressing the fourth ventricle in the brainstem. So the tumor will present according to the structures which are compressed by the tumor, which are involved by the tumor. So in this patient, there will be brainstem sign. There will be, when the fourth ventricle is compressed, so there will be dilatation of the third and lateral ventricles, and the patient will present accordingly. When there are multiple lesions in the brain, we are suspecting metastatic lesions. So if you look at, there are lesion in the frontal lobe, in the basal ganglia, and the occipital lesion in temporal, so there are multiple lesions. While here there is a tumor which is in the supracellular region and also compressing and involving the third ventricle and the lateral ventricle are dilated. This tumor is inside the parenchyma, which might be glioma. And if you look at this one, this lesion with surrounding edema. So in addition to the signs symptoms of raised intracranial pressure, there will be involvement of the motor step, and the patient can have weakness on the opposite side. While here a lesion is arising from the meninges, this is compressing the brain, and this is a typical findings on the MR, that of meningioma, as it is on the left side. And this is the frontal lobe, and this is temporal. In the temporal lobe, there is sensory area for the, that is called vernix area, and there are two main areas for the speech. One is vernix, that is lying in the posterior superior part of the temporal lobe on the left side. So when the vernix area is involved, the patient will not be able to understand. The patient will speak clearly, but the speech will not be according to the question which you ask. So there will be no correlation between his speech and his understanding. While when the speech area, the Broca's area is involved, the patient will understand what you will ask, but he will not be able to express himself. So that will call expressive or motor dysphasia. This is the pituitary region, and the tumor is in the sella in the supracellular region. So in such patient, the optic chiasma is involved, and the patient is having visual field defect and decreased vision. While again there are multiple lesions on both on the right and left with a lot of edema. So when there are multiple lesions and many more edema around the lesions, so the findings are in favor of metastasis. So when we have investigate the patient, then after that we start treatment of these patients. So the management includes history, examination, investigation, and treatment. We have done this one, we have done examination, we have done investigation, then we will discuss about the treatment. So in treatment, what we do, we always divide treatment into these different steps. So when a tumor is diagnosed, we should always counsel the patient and his family, his or her family. So the patient is informed about the lesion. It is told that if this patient is not treated, so the size of the tumor will increase and may further deteriorate him. This patient might need surgery or non-surgical treatment, that is explained, and both the pros and cons of the surgery are advised or explained to them. When the patient is willing, then and consent is taken and the treatment started. By general treatment mean that the patient should be optimized. If the patient is anemic, that should be corrected. If the patient is diabetic, that should be controlled. If the patient is hypertensive, that should be controlled. So this patient should be made fit for the patient should be made fit for the surgery for general anesthesia. Uh, these patients need medical treatment in the form of steroids, in the form of antiepileptics if the patient is having fits. Painkillers can be given for headache, and then surgery is in the form of either that is conventional surgery or recent advances. By conventional, we mean that we go for craniotomy and the tumor is excised, while recent advances sometimes these patients are not operated, but the operation is done either with the help of endoscope or navigation is used for it, or sometimes when the endovascular techniques are also used. So these are the recent advances. When a patient is operated, he or she needs post-op care in the form of medication, in the form of care of the wound. And when the patient is okay, these are later on they are advised about the radiotherapy or chemotherapy, and that is according to the histopathology report and grade of the lesion. And when these patients are stable, they are followed and OPDs in the form of clinical follow-up or radiological follow-up. In rehabilitation, a very important step in management, this patient needs psychosocial rehabilitation. They need uh, physical rehabilitation. They need psychological rehabilitation. So rehabilitation is a very important step of the treatment. So this lesion is arising from this area that where the acoustic nerve is passing. It is compressing the brainstem, the fourth ventricle in cerebellum. So in this patient, there will be decreased hearing. There will be long tract signs because of the involvement of the brainstem. The patient will have hydrocephalus as the fourth ventricle is compressed. There will be finding of the res intracranial pressure and the cerebellum is involved. So cerebellum sign will also be there. So what we do, we go for surgical intervention in the form of posterior fossa craniectomy, and then this is excised. Again, a lesion in the fourth ventricle compressing the brainstem anteriorly and the cerebellum posteriorly, and the fourth ventricle is involved, so the lateral and third ventricle are enlarged, so there will be hydrocephalus. The patient will have findings according to the res ICP. There will be finding of cerebellum like a balance problem, and there will be long tract signs like difficulty in walking. So what we do posterior fossa craniectomy, and then the tumor is excised. This is MRI which is showing a lesion which is involving the bone, and this is a typical uh, presentation and findings of the metastatic lesion. And if you look, the part of the tumor is coming out while part of the tumor is going inside the cranial cavity, and that is compressing the brainstem. So what we do, we excise the lesion and the brain is decompressed, and later on the bone which is excised, then we go for plating or cranioplasty. And again, a skull base lesion which is involving the skull base, sphenoid sinuses, pituitary fossa, and optic region. So this patient might have findings according to pituitary and optic nerve compression as well. Okay, so when we have decided for tumor removal, what we do, we go for craniotomy. And what we do in the craniotomy, first we give a scalp incision, and that is according to the area where the lesion is lying. The scalp is excised, the flap is raised, then we make different burr holes in the skull, and the bony flap is raised, then below the bone we have dura. Then we cut the dura, and then we are in the parenchyma, and when we are in the parenchyma, then the tumor is localized and that is excised. So this is called craniotomy. So what we do in craniotomy, scalp flap, bony flap, and dural flap. Three flaps are raised, and then we are on the brain parenchyma and we excise the tumor. Nowadays, for these remnants of the tumor or for small tumors or for those tumors which are not operable, or when the patient is not fit for surgery, or when the patient is not willing for surgery. So in such condition, we go for cyber knife and gamma knife. What we do, that the radiations are focused on the lesion, and then these lesions are controlled. Some tumors need chemotherapy as well. Nowadays, the role of endoscope is very common, especially in brain surgeries, and especially those surgery which are those tumors which are lying the skull base. So removal of the pituitary tumor through transsphenoidal route is a common practice. And what we do, that the endoscope is introduced through the nose, then we enter into the uh, sphenoid sinus, then the roof of the sphenoid sinus is drilled, and then we are in the pituitary fossa and the tumor is excised. So these endoscopes are also used for intraventricular tumors. They are also used for a lot of other procedures. So endoscopy is also very common. So what can be the complication when we are going for craniotomy or for brain tumor resection? So the risk of complication is always there. There is no surgery which is free of risk of complications. So we should always be ready for that. These complications should be explained to the patient and the relatives. And whenever there are complications, so we should always be there to manage this complication, because the management is very important for the prognosis. So in the cranial cavity, when we are going to operate on the tumor, the patient can have post-op hematoma. There can be infarction when the vessels are coagulated or ligated. There will be swelling of the brain, that is called edema, as we are going to cut through the cortex and entering into the parenchyma to resect the lesion. So these patients have more chances of fits, initially because of the brain tumor and later on because of the surgical intervention as well. When the dewar is not uh, closed properly, or when there is a dural defect, so there can be leak of CSF, and that can lead to meningitis. So that is very important to manage these things. When the motor strip is involved, or when the long tracts are involved, or when the cranial nerves are involved, so the patient can have deficit. So motor strip involvement will lead to hemiplegia. Even sometimes the tumors are extending up to the thalamus, and if you try to resect, and then the patient can have deficit. The lower and posterior for surgery, the lower cranial nerves can be involved, and the patient can have dysphagia. When there is involvement of the speech area, the patient can have dysphagia. So the complication can be according to the location and area where the tumor is. So these are the things just for the repetition. So a lesion can be in the posterior fossa involving the midbrain, the brainstem or cerebellum, and that is the anatomy. What we do with, we give an incision here, and then the bone is resected and the tumor is excised. And here the role of endoscopy. So through this endoscope we can go for taking biopsies from the intraventricular tumors, or even resection of the tumor or aspiration of the cystic lesion like colloid cyst. And through this endoscope we can take biopsies, we can excise the pituitary tumors. So endoscopy has a very important role. And as I mentioned, when a lesion in the posterior fossa, so what we do, that we are doing posterior fossa craniectomy, and then we excise the tumor. So at the end, I would say that to know about the brain tumors, we should always know about the anatomy. If you don't know about the brain anatomy, then we cannot be good and safe surgeons. So to be a safe neurosurgeon, it is very, very important that we should know about the normal anatomy of the brain. Second thing is that to know about the presentation, always think that there will be a general presentation of these tumors as well as presentation according to the location of the tumor inside the cranial cavity. So generally, due to raised intracranial pressure, the patient can have headache, vomiting, the patient can have fits, the patient can have weakness, and if the lesion is in the frontal lobe, the patient will have frontal lobe signs in addition to these common. If there is pituitary tumor, the patient can have will have pituitary hormonal problems with when a lesion is in the motor strip, the patient will have weakness. When there is an involvement of the cerebellum, the patient will have cerebellar signs in the form of loss of balance. When the brainstem is involved in the corticospinal fibers are affected, the patient will have difficulty in walking and the cranial nerves will be involved. So the presentation will be according to the location of the tumor. There are many investigations, but the important investigation in brain tumor is MRI and CT scan. So MRI tells us about the location of the tumor, about the size of the tumor, about the extent of the tumor, about the compression and the surrounding structures. And by looking to these things, then we can decide that which approach will be better for this patient to excise that lesion. So when a brain tumor is diagnosed, that should be properly explained to the patient and relatives. The patient should be optimized. If the patient is willing for surgery, we go for craniotomy and excision of the tumor. Post-op care is very, very important. If we don't go for proper post-op care, then our surgery will be failed and we will have very bad results. Rehabilitation has a very important role. And nowadays, those tumors which are inoperable, like lying in the brainstem or in the structures which are the surgery where the surgery is highly risky, or when a patient is not fit for GA, or when the patient is not willing for surgery. So in such condition, we use gamma knife or cyber knife and we have very good results. Thank you. Thank you. Finished.